Palliative congenital operations serve to either prepare patients for a future conservative cardiac surgery versus heart transplantation or improve symptomatology by reducing cyanosis and relieving the heart failure. While they provide symptomatic movement, they do not address the underlying pathophysiology. A definitive corrective operation may not be feasible option because of the need to prepare existing circulation for corrective operations, or because the patients with low birth weight with advancement in cardiopulmonary bypass and microsurgical techniques indication for palliative procedures are over the years. Palliative operations may be subdivided into four groups on the operative goals: those that reduce the pulmonary blood flow, such as PA banding; those that increase pulmonary blood flow, shunt procedure; those that facilitate intra-atrial mixing, atrial septostomy; other procedures such as those addressing the valvular disease, aortic coarctation, and hyperplastic left heart syndrome. Operation that reduce pulmonary blood flow. A PA banding is performed to reduce the PA circumference with the end goal of reducing the pulmonary blood flow in patients with left to right shunt or the pulmonary overcirculation. Historically, it has been utilized for any small child with large left to right shunt and the pulmonary overcirculation. PA banding is indicated for following condition: Swiss cheese muscular VSD, multiple VSD with coarctation, single ventricle with pulmonary overcirculation, simple transposition, and select patient with congenitally corrected transposition. Criteria to reach adequate tightening of the pulmonary band is increase in systemic pulmonary blood pressure to 10 to 20 millimeters, decrease in systolic PA pressure to 50%, achievement of the lowest possible mean PA pressure. Dressler rule is to calculate the optimal length of PA band by ventricular heart repair 20 millimeter plus weight of the child, and complex mixing defects 24 millimeters plus weight of the child. This is approximation and should be used only at starting point. Operations that increase the pulmonary blood flow. These operations create a systemic to pulmonary shunt with main principle of establishing the limited but balanced pulmonary blood flow. There are classical shunts which have been abandoned and contemporary shunts are addressed. Often systemic to pulmonary shunts are considered in the following congenital lesions: pulmonary atresia with VSD, pulmonary atresia with intact ventricular septum, Fallot's tetralogy, tricuspid atresia, Epstein anomaly, hyperplastic left heart syndrome. The classical shunt include the classic Blalock-Taussig shunt is an end-to-side shunt between the transected subclavian artery and PA. Waterston or Cooley shunt is a side-to-side direct anastomosis between the ascending aorta and the anterior aspect of the pulmonary artery. And there are also port shunt and central shunt. The contemporary shunts include modified Blalock-Taussig shunts, Sano shunts. Modified Blalock-Taussig shunt is a prosthetic conduit between subclavian artery and the pulmonary arteries without division of the subclavian artery. Sano shunt is a shunt created between the RV and PA using the prosthetic conduit. Stenting of the ductus arteriosus is performed by percutaneous stent placement of the ductus arteriosus and has been increasingly used in large congenital defect. The hybrid palliation is defined by combined percutaneous ductus arteriosus stent and surgical intervention. Atrial septectomy or septostomy. These procedures were created to provide mixing of the blood at the atrial level in the indication for transposition of great arteries prior to corrective surgery and for select single ventricle patients. Rashkin balloon atrial septostomy is a catheter-based intervention that have largely supplanted the surgical atrial septectomy and help stabilize the patient. Thank you.